I'm always heartened and saddened to see a room as packed as this. I am saddened because it's obviously evidence of how many people in this community have been touched by the opioid epidemic that is going on. But I'm heartened because you are here obviously to learn, and that is a really good thing. So I'm hoping that I can help with that desire this evening, and if I can figure out how to start the slideshow. I am going to be presenting the slides for Dr. Caleb Bantagreen, who's an epidemiologist at the University of Washington's Alcohol and Drug Abuse Institute. He was unable to make it here tonight, so I'm going to pretend as though I'm an epidemiologist. I've worked with Caleb actually for about 10 years back in the 2000s when I was a research scientist at the Alcohol and Drug Abuse Institute. So both he and I share wanting to understand objectively from a scientific standpoint what do the data show about both the epidemiology of this epidemic and what do we know about the science of treatment for this disorder. So this first slide is looking at two specific forms of opioids. I'm going to use the term opioid tonight because that includes not only naturally occurring opiates like heroin and morphine, but synthetic opioids like methadone, Vicodin, pharmaceuticals like that. Excuse me, grab my water here. So the blue bar on the bottom is codeine, which is an opiate, and it shows the fact that the prescriptions for codeine from the years 1997 up through 2015 were really pretty flat. And that contrasts directly with prescriptions for hydrocodone or Vicodin. So you can see that there was a steady rise in the number of prescriptions for hydrocodone throughout the early 2000s in particular. This rise in the number of prescription opioids over the early 2000s is the story behind this epidemic. Dr. Yu was asking the question, is this actually an epidemic? And I can tell you that there are many organizations that have stated, yes, emphatically, this is an epidemic. So the Centers for Disease Control, the World Health Organization, the White House Office of National Drug Control Policy, the Department of Justice, all of the entities at the federal level have called this a full-blown epidemic. So the story behind what we're going through now is the fact that there were an awful lot of prescriptions for opioids written in the early 2000s. Essentially, the market got flooded with an awful lot of pills, and what do you know, people started using them, both according to prescription, but also some experimentation started. So these prescription trends are very important for you all to understand. You can see that hydrocodone did, as I mentioned, increase all throughout up until 2011 when it finally started declining, and that was after some discussions started happening at the state level about we've got to cut back on some of these scripts. The next slide has those same two medications as the previous one, but it adds in the prescription for methadone. So on the left you'll see a broken line. Those were prescriptions for methadone that were only for the use of chronic pain conditions, again back in the early 2000s. You can see a gap there of 1 year, and then it started up again. And the reason there's a big leap is that the medication methadone is used in the treatment, the medication-assisted treatment for opioid use disorders in programs like the ones that we run at Evergreen Treatment Services. So opioid treatment programs and the amount of methadone that was being used to treat opioid use disorders is included in the second part of that graph. So you can see that, again, the amount of methadone that was prescribed jumped considerably over the course of the decade, and it also started declining after around 2009. There were a couple of different reasons for that. So the flip side of the fact that there are so many prescriptions for opioids out there are the fact that there has been a really significant rise in the number of deaths related to overdoses. And I'm sure that there is more than one family, unfortunately, in this room that has been touched by this. I've talked with, I can't countless numbers of families who've been touched by this, so please know that you are not alone. And again, I applaud you in coming to wanting to learn more. So the blue line, the light blue line in the middle, is deaths due to prescription opiates over time. The green line is deaths due to heroin. And the dark blue line on the top is both of those categories collapsed. You can see that the top line basically parallels the number of deaths due to prescription opioids, so that light blue line, all the way up until about 2010. In 2010, you also start seeing a jump in the number of deaths from heroin. And the reason for that is that this state joined many other states in the use of a prescription drug monitoring program. So if I get written a script for Vicodin from my dentist because I had a tooth pulled, I go to my local Walgreens and I get that script filled. That information is getting loaded up in a state database that allows scripts to be tracked. The reason those databases are so helpful is that it allows doctors and programs like ours to check and see whether or not someone's going from doctor to try to get multiple scripts. So it was a control measure that was very important in trying to bring the overdose death rates down. So prescription opiates became less available, and people who had already become dependent on prescription opiates now started using heroin if they were unable to afford their prescription opiate any longer. So you see an inverse relationship between prescription opiates and heroin. So that's the story there. This map shows the state of Washington at 2 points in time, the early 2000s on the left and 2011, 2013 on the right. And it shows the number of overdoses due to opioids by county. The story when your eyes scan from left to right is if it's darker, that means there are more opioids, more overdose deaths due to opioids. So you can see just scanning that basically the whole state got a whole lot darker, and that there were a couple of states in particular that were in really, really bad shape, notably southwestern Washington. You can see a couple of 200 and 300% there. That's just an astounding increase in the number of overdose deaths. So right now, approximately 600 people per year die in Washington state from an opiate-involved overdose. And that exceeds the number of people who die from motor vehicle accidents. We passed that threshold back in 2009. So we are now having, again, more people die from opioid use than we are from motor vehicle accidents. This next graph is both heartening and disturbing at the same time. So on the left, this is a survey. These are results of a survey that's conducted every year with 10th graders, asking them about their substance use over the past month. So 10th graders are responding to the question, have you used opioids, prescription opiates, to get high in the last month? So you can see it was 10% back in 2006. 10% of 10th graders had used prescription opiates to get high in the past 30 days before they took this survey. That, thankfully, has been coming down considerably. It's been cut in half in just about 8 years. That's actually pretty good. The graph on the right, however, looks at people who, amongst 10th graders who reported that they had used prescription type opioids to get high, 19% had ever used heroin, compared with 3% of those who had not used any prescription opioids. So if you've used opioids off the label to get high, your chances are a whole lot higher that you've also tried heroin. So that's what that means. Not everyone who uses prescription opiates illicitly goes on to become a heroin addict, but only about 4% actually do that. So if I use prescription opiates off label, the chances of me going on to use heroin within the next 5 years is about 4%. So it's not everybody, but it is about 4%. Your chances are significantly increased. So again, you can see risk very early on in these developing brains and bodies with kids who are experimenting with heroin, which is very, very frightening. How do people go from pain pills to injecting heroin? I can't think of a single person who said, I want to grow up and be an IV drug user. That just doesn't exist. But there is a very clear pathway that happens in the brain for this transition to occur. And it starts in the lower left. So people may find pills in mom and dad's medicine cabinet or my friend's parents' medicine cabinet when I'm over there visiting. I might try some. I might buy some from somebody who's hanging around the schoolyard asking me if I want to try some. Turns out I kind of like it. If I like it, I use a little bit more, and then I use a little bit more. And what happens during that time is my body, my brain starts to change. So it's getting used to the fact that I've got opioids in my system. sooner or later, those pills that I'm taking aren't quite making me get the same effect that I used to. In fact, I'm really looking for a little bit more of that oomph that I used to have when I first started using it. At that point, people may crush the pill and actually try to snort it. So that's a faster pathway to the brain than taking it orally and having it filter through the stomach. So that's the next route. After that, people might smoke it. You can actually smoke heroin. And after that point, again, as you continue to go up the ladder, that's when IV drug use happens. So this is not a pathway of, I want to try this, I want to see what it's like to inject. It's really driven by some important physiology that happens, and I have a number of slides that are going to build on this. I think that was the last of Caleb's. So let me switch over to mine, and we will continue this story. Perfect, thanks. So I'm going to tell the story, I'm going to continue the same theme that we have started, which is that there's a very predictable pathway that happens, and it's fully explainable what happens to people when they, same slide, you can see Caleb and I work together. This slide actually shows the story of why people move to those different routes of administration, so oral versus smoking versus injecting. If you or I, or someone who had never taken opioids before, took a pain pill, because I was in a lot of pain, I would start out in that middle area called normal, where I don't have any tolerance to the medication. I would take the drug and I would feel the drug effect. We're labeling that euphoria here because we're talking about people who are abusing the substances or using it illicitly. So I take the pill, I get a drug effect, and then a couple hours later, depending on what kind of medication I take, the drug wears off and I end up back in my band called normal. I take it again, I go back up, and this roller coaster starts. So what happens over time is you can see that the time spent up in that blue euphoria box gets a little bit less and less. In fact, on the far right-hand side of the graph, people don't even get there anymore. So as bodies become more familiar with opioids in there, and I need more and more in order to get the same effect, I'm not actually getting that same effect. In fact, what I'm starting to experience more and more are classical symptoms of withdrawal, and that's the red bar at the bottom. So you can see I've gone from going to normal into feeling high and hey, I kind of like this stuff, into man, I feel pretty bad most of the time, and all I'm trying to do is feel normal. This is the life of the patients that we see in our treatment program. These are people who are really miserable. They feel terrible. They've lost most things. They've lost relationships. They've lost jobs. They've lost housing. They've lost self-respect. They've lost spiritual direction. They've lost all kinds of things, and they really just want to get back to what it used to feel like at one point in time in order to feel normal. So that process over time occurs because bodies get accustomed to having opioids. So tolerance is part of the syndrome of an official opioid use disorder, and that's the term that I use, opioid use disorder, instead of addiction. It's a medical term, and the tolerance means that you need more and more in order to produce the same effect. So it's just like if you have a beer when you go home after work, or a glass of wine, and sooner you need two in order to feel that same effect. It's the exact same mechanism that happens here. Withdrawal is what happens if my body is used to that substance, but all of a sudden I don't have it in my system anymore. So there are predictable signs and symptoms of withdrawal, both physically, dilated pupils, goosebumps, nausea, and psychologically, panic. I start thinking more and more, where am I going to get my next fix? I start getting kind of obsessed with the drug. So those are the classic symptoms of dependence. So my area of expertise is medication-assisted treatment for opioid use disorders. This is one tool for the treatment of opioid use disorders. It's not the only tool. For communities like yours, I always say we can't predict who is going to do well with which kind of treatment, so it's important for communities to have a full toolbox. You need abstinence-based programs, you need methadone programs, and you need Suboxone programs or buprenorphine programs. So I would encourage you who may not know much about medication-assisted treatment to keep an open mind about the story that I'm about to tell you, and to think of it as just an additional tool in your toolbox at the community level. So addiction is known, substance use disorders are known to be a chronic relapsing medical disorder. So there was a tremendous amount of brain science that was done at the National Institutes of Health and the National Institutes on Drug Abuse back in the 2000s, the 1990s and 2000s. And they did a tremendous amount of brain research that had never been done before. And they found that with opioid use disorders, in fact, many kind of substance use disorders, it's the brain's reward system and the decision-making process that, in particular, they get affected when someone tips over into the area of a disorder. So the medical community at this point, and the policymakers are catching on, are understanding that addiction is similar to hypertension and diabetes. It's a chronic relapsing medical condition. Just like hypertension and diabetes, there are some people who may come in for a course of treatment. They may only need one course of treatment. They either are on medication for that or not, but they are able to go off on their way and do very well without any additional treatment. There are a lot of people, though, again, just like with hypertension and diabetes, who go through relapse over and over and over again, and I have no doubt that there are people in this community who have also been through that. We don't know which camp people are going to be in, so the treatment is a very imperfect science at this point in time, which is another reason that it's important for a community to have many different tools in your toolbox. The reason that medication-assisted treatment has become understood as the medical standard of care at this point in time, it is considered that, is that the medication helps stabilize that roller coaster slide that I just saw you, and it keeps people in that bar called normal. So if the medication, there are two medications right now that are approved at the federal level, the Food and Drug Administration, for the treatment of opioid use disorders. There's Methadone and Buprenorphine or Suboxone. Suboxone's the trade name, so I tend to call it Buprenorphine. Those two medications are very long-acting, and if they're prescribed or dispensed appropriately, people don't get high off it, they don't get the euphoria, but it keeps them out of that withdrawal pit, which is what's driving ER use, it's driving criminal activity, it's driving prostitution, it's driving lying and stealing and everything that probably brings all of you to this room here tonight. So the medication-assisted treatment does work because it keeps people stably in that middle bar. And there are literally thousands of peer-reviewed scientific journal articles that demonstrate that medication-assisted treatment cuts down on crime, it cuts down on health expenses, particularly emergency services, police responses, and it's a very effective investment by the community. It's actually cheaper to provide medication-assisted treatment than it is to allow it to go untreated. If you don't believe me, I'm happy to give you the reference for a study that was done here in Washington to that effect. So policymakers, the medical community, understand that addiction doesn't get cured, it gets managed. It's not a dichotomous state. It really is a chronic relapsing medical condition. So that's the terminology that is really being used in community meetings like this now, and with all people who are trying to get together, trying to figure out how to bring their community back to stability. The goals of medication-assisted treatment. Again, we have 4 treatment programs. We've got 2 in the Seattle area, 1 in Olympia, and 1 in Hoquiam. Hoquiam I came and spoke to a community forum much like this out in Hoquiam. They also were devastated by opioids in their community, and they approached us to open a clinic out there because there was nothing out on the Olympic Peninsula. We have the only 2 right now in existence. We've got our clinic in Hoquiam and in Olympia. We are finding that we've got patients who literally travel, and I kid you not, 2 or 3 hours a day, every day, 6 days a week in order to get their medication and stay stable. So there's something that is working for them, and people are needing this treatment option out there. The goal of medication-assisted treatment is to stabilize the body. Again, is avoid that withdrawal dip that I was describing, alleviate craving, and to normalize the brain functioning. If it's done correctly, again, patients don't get high from it. The second piece is once the brain and the body get stabilized, because people aren't going through this anymore, then the more important, or the equally important part of recovery is what is addressed in medication-assisted treatment. So patients in our treatment program, just like in abstinence programs, need to understand what drove them to begin to experiment, if that was their pathway to this. They need to understand that this is a chronic relapsing medical condition that they need to keep their eye on, potentially for the rest of their lives. That we don't know how long they need to be in treatment. As I said, this is a very inexact science at this point in time. But the medication, we also know, is life-saving. So patients enrolled in our treatment programs have a 50% less overdose risk rate than people who are not in treatment. So being in medication-assisted treatment reduces the likelihood of people overdosing and dying by 50%. There are 3 different kinds of treatment. You've already heard me mention methadone and buprenorphine or Suboxone. There's a third one called Vivitrol or naltrexone, which has a different mechanism of action. So I'm going to describe, we work with the first 2 medications, and I will describe those for you. There are other primary care providers, and some folks in the criminal justice system have interest in Vivitrol. So how do the medications work? What you're looking at here is a graph of, along the right hand, if you give more and more of the drug, what is the effect that you get there? So with methadone, think about a lock and a key. The lock fits perfectly into, the key fits perfectly into the lock and turns it on fully. That describes how the medication works in the receptors in the brain that are responding to the repeated use there. So methadone is very effective because it binds really tightly in those receptors. But there's a risk with it. If you give more and more of it, people can overdose and die. And that was the problem with writing prescriptions for methadone for chronic pain conditions back in the 2000s. It has a very long half-life, so if you're an active heroin user, you're probably shooting up or snorting or smoking, whatever you're doing, somewhere every 4 to 6 hours, because it's a very short half-life for that drug. Methadone has a half-life of 24 to 36 hours. So if somebody takes their medication at the same time every single day, they get up to the right blood level, and again, then they just stay there. They don't do this. It's a flat curve up there. So methadone works very effectively because it's long-acting. Buprenorphine is also very long-acting. It's also 24 to 36 hours in its half-life. It's got a somewhat safer safety profile than methadone. So that lock and key metaphor isn't quite as effective. It works, but it's kind of like the door is still kind of partly open. So you can stabilize somebody on buprenorphine, but there's a ceiling effect. So it doesn't have the overdose risk that methadone does, but it can stabilize people if they respond positively to that medication. Again, we don't know who's going to respond to methadone or buprenorphine, just like we don't know who's going to respond to one antidepressant versus another or one hypertension drug versus another. It's the exact same concept. So both of these medications are really useful. They need to be managed responsibly, and they need to be done by professionals who understand how they work. Naloxone or Vivitrol is a third medication, and that's kind of like gum in that lock. So it blocks the effect of opioids. So if I have, it's given by a shot in the butt once a month is one of the ways of administering it. It blocks the effect of opioids so that if I try to inject heroin while I have Vivitrol on board, I won't feel anything because all my receptor sites are totally blocked. Sounds good, right? But if I get into a car accident and I've actually got a legitimate pain condition, I can't be treated for that. And there's also, people have to go back over and over again for the shot, and then there's a little bit of a window during those re-administration periods that people need to be careful of because they can kind of sneak through there and relapse. So 3 different medications, 3 different functioning, all very effective. So again, the graph I repeat here only to emphasize the fact that all 3 of those medications are designed to keep people in that white bar there called normal. Excuse me. This is, I like presenting this. This is from the 1960s. And it's real data from a real patient that was studied by the inventors of methadone as an effective treatment for opioid use disorder. So you can see the 3 same bars that I just showed on that other graph there. People feeling euphoric or straight or normal or sick or in withdrawal. And this is actual administration from somebody who was a participant in the study who was given free access to heroin. So the researchers were monitoring when were they injecting. So you can see they inject right when they woke up at 8 o'clock in the morning or whatever time it was. They get up into that euphoria, and then they're trying to stay up there. But when they fall asleep at night, they wake up and they're in withdrawal. So they inject again, they're trying to get back up there. If they don't have enough of a dose, they won't ever get back to that place. And you can see what happens on the far right is the risk of overdose. This is what it feels like to be on medication-assisted treatment for opioid use disorders. Again, the dots represent when the medication dose is given, methadone, and it keeps them in that narrow curve. So, to repeat myself, medication-assisted treatment blocks the euphoria, it stops the withdrawal symptoms, allows people to feel normal, and it allows them to engage in recovery. I want to add that there's been a lot of stigma and misunderstanding about methadone and medication-assisted treatment over the years, and importantly, in the last couple of years, the Hazelden Foundation and the Betty Ford Foundation have both come out in support of medication-assisted treatment. So the 12-step community is understanding that this is an effective tool for helping some people, prevent relapse and to remain stable. So in the big book, there's actually reference to medication being available for use for helping people into recovery. So it's an interesting kind of piece of history of that movement. I always try to say, what's the difference between a drug and a medication? Because some people will say, aren't you just given one drug and substitute for another? In my world, a drug is used to enhance or to change reality. It allows me to escape it. A medication is one that allows me to participate in it. So whether I'm taking it in order to stabilize my opioid use disorder or because I have hypertension or an antidepressant, all those medications are really designed to allow me to engage in life more fully. The difference between many medications will result in somebody getting physically dependent on them. Again, you can think of insulin for diabetes. People are physically dependent on that, but they aren't addicted to it. The difference really has to do with the psychological component of obsessing, craving, thinking about it all the time, rearranging my life in order to figure out how I'm going to get my next fix, etc. So the difference between, again, dependence and addiction is the psychological component. In our treatment programs, the way that it works is we happen to work with everybody who comes to us voluntarily, so folks are not court-ordered. People call us up, they go through a complete psychosocial intake, so we try to understand the full areas, impact of the breadth of the areas in their life that have been impacted by their opioid use disorder. And then they meet with one of our medical providers, usually an ARNP or physician's assistant, who says, yes, this person is dependent on opioids. At the point that patients get admitted, they will come to our dispensary and they must take their medication in front of a registered nurse who assesses them every day to see whether or not they're appropriate for receiving that medication that day or whether there are signs of them being impaired, in which case the nurse will say, I either can't give you your dose today, or you need to give us a urine sample, or you need to come back in a couple of hours and let me reassess you. So 6 days a week, observed medication dosing with a registered nurse, at least monthly random observed urine drug screens, mandatory counseling for all of our patients. We check that state database I mentioned before to make sure that patients are being honest with us about the scripts that they're getting and that we can coordinate care with doctors. If we find out that a patient has gotten a script for an opiate that they haven't told us about, then they go down a different pathway and we have a different conversation. If they coordinate with us, we verify the fact that they are getting, again, they're not at risk for overdose and that it's a legitimate concern that's being prescribed for. They have regular appointments with our medical providers, and then once they stabilize and they start doing everything right, they come every single day for treatment, they go to every single counseling appointment, all their urine drug screens show nothing else other than the methadone, which they should be taking, or the buprenorphine. Once they start doing all of those things, we start awarding them one additional take-home dose a week. So clinics open 6 days a week. Everybody gets a Sunday take-home dose right at the get-go. Patients get a break, we get a break, and then we start it all over again on Monday. So over time, patients can earn one additional day per week where they get a take-home dose. And that's a privilege, and we check them on whether or not they are keeping their medication safe at home, whether or not, again, we test them with urine samples to make sure that it's not being diverted. We have to be responsible not only to our accrediting body, but also to our communities to make sure that we are doing all that we can to make sure that the medication is safe and accounted for. We also offer acupuncture in our clinics because acupuncture can help calm people down, help them stabilize in their emotional world, can also help calm anxiety. It helps many patients actually give us the urine sample that they really don't want to give us. So this slide shows what happens over time. So at the point that patients get admitted to us, most people are using a lot of substances. The days of seeing people who are using only opiates are, they're not gone, but it's much less common. Now we're finding a lot more co-use of methamphetamine and alcohol, benzodiazepines in particular. So at the beginning, most of the patients come in with a positive urine sample. They have to have a positive urine sample for opiates or else we won't admit them into the treatment program. But you can see it takes a long time for people to get their use stabilized. And again, we are working primarily with a Medicaid population, so these are folks who are low income, who have probably lost things like a job and housing, and typically have had many years of substance use disorder in their history before they come in through our admission door. So it takes time for them to stop using all the other substances. It takes time for them to accept the fact that they've got a chronic relapsing medical condition that they really need to watch carefully, and then they need to determine for themselves how effective the medication is for them. They need to believe that either this is really helpful for me or it's not. So we let them decide that. It's not ours for them to choose. One of the reasons that medication-assisted treatment is really helpful is that there is typically, again, this is not for everybody, but there's typically a very high relapse rate after people leave treatment, particularly if they leave there, they kind of blow out of there, they leave prematurely. We do have some patients who slowly taper off the medication and do quite well. That's a voluntary discharge, and that's not included here. But if we have people who say, I'm out of here, I don't want to do this anymore, the relapse rates within a 12-month period can be as high as 90%, 95%. And again, those are folks who are at particularly high risk for overdose. People who blow out of medication-assisted treatment and start using again, people who come out of hospital settings and jail settings where they've not had anything in their system and they go back to the same dose of whatever it was that they were using, they're at a much higher overdose risk rate at that point in time. I'm going to quickly just review Suboxone. Suboxone or buprenorphine can be prescribed by a primary care physician in the community, and I would encourage this community to figure out whether you have a Suboxone prescriber already or how you might get one. There are a lot of very innovative models that are being tested in the state of Washington and nationally right now about getting the primary care system involved in the treatment of opioid use disorders right now. So this is different than the program that I just mentioned for you. So primary care and specialty clinics can write prescriptions for Suboxone, as well as substance abuse treatment programs like ours. We have an outpatient Suboxone program as well. Again, the functioning is very different than methadone. It's got a safer profile, which is one of the reasons that it's okay to write prescriptions from a primary care setting, because there's not as much of an overdose risk. If people take more and more of it, they actually don't get any more of the same effect. It flattens out. So it's got a better safety profile. The advantages are it can be prescribed by a physician. So unlike programs like ours, which take a lot of money and time and community support in order to open, any physician can get approved by the federal government to write a script for Suboxone. It's a very effective medication. There's limited overdose potential. There's minimal subjective effects, meaning that, again, I don't keep getting high. I flatten out on that experience curve that I showed you on the slide before. There's a lower level of physical dependence, so it's a little bit easier to come off of it than it is with methadone. And in combination with naloxone, so buprenorphine plus naloxone equals what is called Suboxone. There's reduced abuse potential. So the reason those two medications are together is that it reduces the likelihood of diversion. So when buprenorphine first came out, people were very quick to figure out, hey, if I just crush this and liquefy it, I can inject it. So they added naloxone with the buprenorphine so that if I went through that course, it would actually throw me into withdrawal, which is not what I'm after at all. So it's an effective deterrent for abuse. The black market for buprenorphine is, there's data on this. We've collected this at several syringe exchanges around. People buy Suboxone on the black market because they want to avoid withdrawal. It's the primary reason that people are seeking Suboxone. But you can't control a medication that's received from a prescription. So there's less control in the community with Suboxone than there is with Methadone. Opioid use does decrease with a higher dose of buprenorphine, and with our patients we find somewhere between 16 and 20 milligrams is about the right average daily dose. So this is a slide around, don't under-medicate, make sure that people can have enough in their system so that the medication has a chance of actually having the correct effect. Which medication? Again, we can't predict who will do better, so all we have is trial and error. If someone's never been in medication-assisted treatment before, then I would typically try them out on Suboxone because, again, it's a little bit easier to get off. If they fail that after a couple times, I'd probably try them on Methadone. It's a different medication, different form of action like I described earlier. So successful treatment in medication-assisted treatment involves trial and error, and we need a full toolbox of options. So it doesn't make medical sense to limit what the available medication choices are. There's some communities that say, and there's a variety of groups who say, I don't like methadone, we're never going to let methadone in this community. It simply doesn't make medical sense. I'm not a medical doctor, but it doesn't make medical sense. And again, forcing people to stop medication for a variety of service scenarios, in particular the criminal justice system has had this in some places still currently. There are some courts and some jurisdictions that will say we will not allow a patient to be on medication-assisted treatment and consider them in compliance with their court program. That just doesn't make sense because you're asking to return people back to seeing their kids on the condition that they get off their medication that's keeping them stable. It really does not make any sense. So this is an important message that I always try to give. So 3 takeaways from my talk, please. Addiction is a chronic relapsing medical condition. It affects the brain. It is the management of a chronic medical condition, which we would call recovery. Medication-assisted treatment does work. People do recover. I've got some fabulous patient stories of people who have been in and out of treatment 20 times, and then they are finally able to get stabilized on medication-assisted treatment. And lastly, again, treatment does benefit the community. Crime rates decline, costs decline. It is less expensive to fund medication-assisted treatment, mostly through Medicaid in this state, than it is to go on the costly expenses of paying for emergency room visits and criminal justice costs. So with that, I thank you, and I will pass the microphone on to the next speaker.
Thank you.